mobile phone data are increasingly used in public health management and disease outbreak response, as demonstrated during the COVID-19 pandemic when location data were used as a proxy for human movement. However, a new study led by researchers at Penn State revealed that phone data may not accurately reflect under-resourced or particularly vulnerable populations who are often underrepresented in other data as well. If this bias is not acknowledged or complemented with additional data, the researchers said a reliance on phone data in public health efforts could magnify health inequalities. They published their findings in the journal PLOS Digital Health. Data gaps exist in all contexts and can be easily seen in small rural populations. In this study, the researchers investigated phone ownership, mobility and access to healthcare in a mobile rural population in Namibia as a case study to measure mobile phone data representativeness in populations that regularly experience vaccine-preventable infectious diseases. Namibia is a middle-income country in southern Africa. Mobile phone data from the region are used to guide public health decisions around malaria and other infectious diseases. Most Namibians live in urban areas with reliable access to healthcare, but this is not the case for rural or remote populations. The research team conducted detailed surveys of more than 250 people at 2 settlements in a remote area of the Kunin province. Residents are largely nomadic, moving seasonally to herd cattle, and the distance to the nearest health clinic is substantial. The researchers found that phone ownership was relatively low, with only 31% of participants owning a phone, compared to the estimated 95% in urban areas in the country in the year 2013, and only 59% having used a phone in their lifetime. Phone owners and users were far more likely to be men, to travel to more locations and to have better access to healthcare. The researchers found that within these already vulnerable populations, the most vulnerable people were underrepresented in this phone data because they didn't own phones or have access to phones. One common way to make up for missing data is to simply scale it up and assume that missing data are the same as recorded data. But the research distinctly found that the people missing in phone data are less mobile with reduced access to healthcare. And with respect to making public health decisions, these are very important differences. Mobile phones also provided a skewed perception of mobility among phone owners. Because phone owners frequently travel to areas with no phone reception, many of their movements would not be captured in phone data. Even if you own a phone, you can only be tracked in locations where you get signal. So, phone data, especially from remote areas, will only capture a specific segment of the population and can record only some of their movements. If phone data were used to predict the potential spread of an infectious disease in a region like the one the researchers studied, most movements and contacts would be missed. Without accounting for data biases, movements based on phone data would be misleading and ineffective for outbreak response efforts attempting to limit the spatial spread of a disease. Because mobile phone data may not accurately represent the populations and the locations that most need public health improvements, the researchers suggested that relying on this data to inform public health decisions can actually be harmful and potentially magnify health inequalities. They stressed the importance of acknowledging and measuring bias in all types of data, not only those used for public health, as well as using multiple types of data with non-overlapping biases when drawing conclusions.